Cutaneous manifestations of gastrointestinal and liver diseases. Lawrence A. Mark 25. Vesiculobular skin diseases. The vesiculobular skin diseases include pemphigoid, pemphigus, epidermolysis bullosa, EB, erythema multiforme, M, and the Stevens-Johnson/toxic epidermolysis spectrum. They may have oral and GI manifestations, as discussed later. Pemphigoid is a general term for heterogeneous blistering disorders characterized by serum immunoglobulin, Ig, G or IgA autoimmune antibodies directed against 230 kD and 180 kD hemidesmosomal proteins, among other keratinocyte antigens, located at the squamous epithelial basement membrane. This antigen-antibody reaction leads to loss of adhesion between the epithelium and its supportive basement membrane substrate. Pemphigoid clinically presents with tense bully and ulcers affecting the mucosa of the oral cavity, pharynx, esophagus, anus, conjunctiva, and skin. Oral findings appear as highly inflamed, erythematous, mucosa on the buccal and gingival mucosa. Two types of pemphigoid have been identified: bullous pemphigoid, autoimmune and drug-induced variants, and cicatricial, mucous membrane, pemphigoid. Patients with bullous pemphigoid typically have skin lesions, and about 1/3 also have mucous membrane lesions. The autoimmune subtype most often presents in the older population and may be preceded by a non-bullous, intensely pruritic, urticarial phase of disease. Drug-induced bullous pemphigoid has been associated with thiazide diuretics, antibiotics, e.g., penicillins, vancomycin, NSAIDs, angiotensin-converting enzyme, ACE, inhibitors, e.g., captopril, and possibly angiotensin receptor blockers, ARBs, e.g., valsartan, among many others, with less literature support for their causative nature. 1. Discontinuation of a suspected offending agent is primary therapy. In contrast to bullous pemphigoid, all patients with cicatricial pemphigoid have mucosal lesions, and about 1/3 also have skin lesions. Ocular symblepharon, i.e., adhesion between the tarsal and bulbar conjunctiva, commonly occurs with cicatricial pemphigoid. Potentially fatal upper GI bleeding from esophageal involvement by pemphigoid has been reported. 2. For all types of pemphigoid, immunofluorescent staining of involved mucosa and skin is diagnostic, showing linear deposition of antibody and complement in the basement membrane zone. Patients with elevated serum IgG and IgA autoantibodies are more likely to respond to systemic medications. Treatment ranges from low-dose to high-dose prednisone. Alternative therapies for patients with contraindications to glucocorticoid use or with systemic toxicities from glucocorticoids include dapsone, tetracycline, and nicotinamide in combination, azathioprine, chlorambucil, plasma exchange, IVIG, cyclosporin, cyclophosphamide, methotrexate, rituximab, and infliximab. 3. Pemphigus vulgaris differs from pemphigoid in that the serum autoantibodies are directed against intercellular keratinocyte proteins, causing loss of cell-to-cell adhesion. This antigen-antibody reaction leads to bullous skin lesions, often flaccid, that can be life-threatening if untreated. Oral involvement can be extensive. Mucosal involvement can cause poor nutrition and severe pain. Half of patients with pemphigus vulgaris present with oral lesions, and oral lesions occur in almost 100% of patients during the illness. Direct immunofluorescence of biopsy material is diagnostic, showing IgG antibodies and complement on the surface of squamous epithelial cells. Indirect immunofluorescence detects circulating IgG antibodies in most patients with pemphigus vulgaris. Treatment consists of various regimens of topical or systemic prednisone, sometimes supplemented with cytotoxic or immunosuppressive drugs. Paraneoplastic pemphigus shares features of pemphigus vulgaris and M. It is associated with GI malignancies, lymphomas, leukemias, thymomas, and soft tissue sarcomas. Features that characterize paraneoplastic pemphigus include: 1. Painful mucosal erosions and a polymorphous skin eruption. 2. Intraepidermal acantholysis, keratinocyte necrosis, and vacuolar interface reaction. 3. Deposition of IgG and C3 intercellularly and along the epidermal basement membrane zone. 4. serum autoantibodies that bind to skin and mucosa epithelium in a pattern characteristic of pemphigus, as well as binding to simple, columnar, and transitional epithelia, and 5. Immunoprecipitation of a complex of 4 proteins, 250, 230, 210, and 190 kD, from keratinocytes by the autoantibodies. 4. The prognosis of paraneoplastic pemphigus is generally poor because symptomatic improvement depends on successful treatment of the underlying malignancy. Epidermolysis bullosa EB is a heterogeneous group of rare inherited disorders of skin fragility, Fig 25.1. They are characterized by the formation of blisters with minimal trauma and are divided into dystrophic, scarring, junctional, and simplex forms. Oral erosions, premature caries, and gingival involvement, as well as GI disease, are common in the dystrophic form, but also occur in some patients with the junctional form. In addition to oral erosions, esophageal strictures are the most common GI complication in dystrophic EB. 5. They most commonly occur in the upper third of the esophagus but may also be found in the lower third. The esophageal strictures are probably induced by repeated trauma from food and/or refluxed gastric contents, therefore, strict adherence to a soft food diet remains a mainstay of management. Although dilations with bouginage historically have been shunned because of an unacceptable risk of increasing esophageal stenosis over the long term, evidence supports the use of balloon dilation as a safe and efficacious method of palliating esophageal strictures without this risk. Esophageal resection, feeding gastrostomy, and colonic interpositioning have been effectively used in dystrophic EB patients with severe esophageal strictures. Esophageal webs in the post-cricoid area have also been described. Anal stenosis and constipation, with or without stenosis, are frequent in patients with dystrophic EB. Junctional EB has been uniquely associated with pyloric atresia. Anemia and growth retardation frequently develop in patients with severe dystrophic and junctional EB, partly because of GI and oral complications. Patients with clinical lesions identical to the dystrophic forms of EB but with no family history and an adult onset have been identified. Their condition is called acquired EB or EB acquisita, EBA. EBA, like pemphigus and pemphigoid, is an autoimmune disease. The autoantibodies in EBA are directed against type 7 collagen. The diagnosis of EBA is established by routine histology and direct immunofluorescence examination of skin biopsy specimens. Like patients with cicatricial pemphigoid, EBA patients may have significant mucosal involvement, especially oral and esophageal disease. Coexistent Crohn's disease has been reported in a number of patients with EBA. Treatment is with immunosuppressive agents. Erythema multiforme M is an acute mucocutaneous eruption associated with underlying infections, especially HSV. It is often preceded or accompanied by low-grade fever, malaise, and symptoms suggesting an upper respiratory tract infection. The eruption consists of alternating pink and red target lesions on the elbows, knees, palms, and soles, and of shallow, broad oral erosions. Patients with M may only have oral involvement. Variable degrees of nonspecific erythema are found, with or without ulcers. Crusting, hemorrhagic, and moist lip ulcers may be present. Severe oral and pharyngeal pain, secondary bacterial and fungal infections, and bleeding are common complications. The diagnosis is made by clinical characteristics, excluding other specifically diagnosable diseases, and by response to treatment. The biopsy reveals a nonspecific interface reaction. Oral M can be self-limited or chronic, and often the inciting process goes unidentified. Management includes palliative measures and elimination of any offending agent. Often, glucocorticoids and/or other immunosuppressive drugs are needed. Recurrences and flares have variable patterns. Herpes-associated M lesions are treated with episodic or suppressive antiviral therapy with acyclovir, valacyclovir, famciclovir, or foscarnet. 6 Stevens-Johnson syndrome/toxic epidermal acrolysis spectrum. Stevens-Johnson syndrome, SJS, with between 10% and 30% skin sloughing, and toxic epidermal acrolysis, 10, with more than 30% skin sloughing, are diagnosed when severe, acute, painful targetoid lesions and skin sloughing occur in association with eye, skin, and mucous membrane involvement. In contrast to M, which is usually infection-related, SJS and TEN are almost always caused by a reaction to a medication, such as an antibiotic, especially a sulfonamide, or an anticonvulsant. Diffuse oral and pharyngeal ulceration may prevent oral intake. At endoscopy, the esophagus may show diffuse erythema, friability, and whitish plagues that can be mistaken for candidiasis. Diffuse gastric and duodenal erythema and friability may be present without esophageal involvement. The colonoscopic appearance may resemble severe ulcerative or pseudomembranous colitis. However, colonic biopsies show extensive necrosis and lymphocytic infiltration, without crypt abscesses or neutrophils. This pattern is reminiscent of graft versus host disease, see Chapter 36. The mucosa of large portions of bowel may slough in SJS, accounting for reports of hematemesis, melena, and intestinal perforation. Treatment largely consists of discontinuation of offending pharmaceutical agents, often anticonvulsants or antibiotics, hospital admission to a burn unit, if possible, and supportive care by a multi-team approach. No reliable evidence exists for the use of systemic glucocorticoids, intravenous immune globulin, or plasmapheresis in the treatment of SJS/TEN, but weak evidence suggests that cyclosporin may reduce disease progression and mortality when used early in the disease course. 7 Lichen planus, LP, is a common chronic inflammatory disorder involving the mucosa and skin. The disease usually begins in adulthood, and 2/3 of patients are women. Oral lesions are variable in their presentation and may appear as white, lace-like, and slash or punctate patterns on any mucosal surface, Fig 25.2. Mucosal erythema or ulceration is common. Oral lesions may appear as asymptomatic lace-like plagues on the buccal mucosal or as painful erythematous or erosive plagues involving the tongue, buccal mucosa, or gingiva. Topical and/or systemic glucocorticoids are effective in decreasing the signs and symptoms in almost all cases of oral and cutaneous LP. Topical tacrolimus is an effective steroid-sparing treatment alternative. Esophageal LP may present with progressive dysphagia and odynophagia, upper GI bleeding, strictures, and squamous cell carcinoma. 8 The endoscopic findings include erythema, ulcers, proximal esophageal. Fig 25.1 Characteristic lesions resulting from skin fragility caused by severe recessive dystrophic epidermolysis bullosa. Courtesy Dr. Benjamin Lockshin, Silver Spring, MD. Chapter 25 Cutaneous manifestations of gastrointestinal and liver diseases. 361 25 Webs, and erosions throughout the esophagus. An increased prevalence of chronic liver disease, including chronic hepatitis C and PBC, has been reported in patients with LP. Oral LP may be associated with an increased risk of squamous cell carcinoma arising in areas of atrophy or erosion, regardless of treatment. 9,10 Bullous LP may occur with cancer immunotherapy agents that inhibit programmed death. 1. Anti-PD. 11 Cutaneous manifestations of inflammatory bowel disease. Both Crohn's disease and UC may be accompanied by cutaneous manifestations, see chapters 115 and 116. Skin lesions are more common, up to 44%, and often more specific in Crohn's disease than in UC. It is rare for cutaneous involvement by Crohn's disease to appear before symptomatic bowel disease. The most common cutaneous complication of Crohn's disease is granulomatous inflammation of the perianal or perifistular skin, which occurs by direct extension from underlying diseased bowel. Metastatic Crohn's disease refers to rare ulcerative lesions, plagues, or nodules that occur at sites distant from the bowel. Such lesions favor intertriginous areas such as the retroauricular and inframammary regions. On histologic study, local cutaneous extension and metastatic Crohn's disease show sarcoid-like granulomatous inflammation, and both occur with greater frequency in patients with colonic involvement by Crohn's disease. 12 Oral manifestations of Crohn's disease occur in 4% to 14% of patients and include aphthy, lip fissures, cobblestone plagues, cheilitis, mucosal tags, and perioral erythema. Patients may also complain of metallic dysgeusia. Aphthosis occurs in approximately 5% of patients with Crohn's disease, and the lesions are clinically and histologically indistinguishable from typical aphthy. Aphthosis and perianal parafistular ulcerations are not seen in ulcerative colitis. Granulomatous cheilitis is a rare condition with recurrent lip swelling that leads to enlargement and firmness of the lips. A lip biopsy shows non-caseating granulomas. In rare cases associated with Crohn's disease 13, this condition may be a component of Melkersson-Rosenthal syndrome, scrotal tongue, lip swelling, with or without facial palsy and migraine, or may be idiopathic. Pyostomatitis vegitans, Fig 25.3, and its cutaneous counterpart, Pyoderma vegitans, is characterized by pustules, erosions, and vegetations involving the labial mucosa of the upper and lower lips, buccal mucosa, and gingival mucosa, as well as the skin of the axillae, genitalia, trunk, and scalp. Both pyostomatitis vegitans and Pyoderma vegitans are specific markers of IBD, Crohn and ulcerative colitis, and may precede the GI symptoms by months to years. Histologically, intraepithelial and subepithelial eosinophilic miliary abscesses are characteristic. Superficial pustules coat the friable, erythematous, and eroded mucosa of the oral cavity, least commonly the floor of the mouth and tongue. Symptoms may be severe or minimal. Eosinophilia and anemia are common. Diagnosis is made from biopsy findings, and treatment is with topical or systemic glucocorticoids, dapsone, or sulfasalazine. Erythema nodosum is a common inflammatory disorder of the subcutaneous fat, with a marked predilection for women. Lesions characteristically appear as 1 cm or larger, shiny, tender, deep red nodules on the anterior shins. The pathogenesis is unknown. The causes of erythema nodosum are infections, especially streptococcal, systemic fungal, and tuberculous, medications, especially oral contraceptives, and leukemias. Erythema nodosum develops in 7% of patients with Crohn's disease and 4% of patients with ulcerative colitis. In addition, GI infections with Yersinia enterocolitica, Shigella flexneri, and Campylobacter jejuni have been associated with erythema nodosum. Treatment of the underlying disease, strict bed rest, and elevation of the legs, as well as the use of anti-inflammatory drugs or potassium iodide, are effective. Pyoderma gangrenosum is a non-infectious ulcerative cutaneous disorder of unknown pathogenesis, Fig 25.4. The classic lesion is a tender or painful ulcer with an elevated, dusky purple border that is widely undermined. One or multiple lesions may occur. Lesions begin as small papulopustules that break down very rapidly. Pathergy, the appearance of new ulcers at sites of minor trauma or surgery, is often present. The diagnosis is one of exclusion, in that infectious and other causes of ulceration, including factitious dermatitis, must be ruled out. Most cases of Pyoderma gangrenosum occur in patients with no underlying disease. Pyoderma gangrenosum develops in approximately 5% of patients with UC and 1% of patients with Crohn's disease. The bowel disease may be subclinical when the skin lesions appear, and therefore bowel evaluation, especially of the rectum and distal colon, is essential in cases of Pyoderma gangrenosum. If the disorder is associated with underlying bowel disease, therapy of the bowel disease may lead to improvement of the skin lesions. The usual management of Pyoderma gangrenosum includes local wound care, high-dose systemic glucocorticoids, or steroid-sparing immunosuppressive agents, such as azathioprine, mycophenolate mofetil, methotrexate, and cyclosporin. 12 Vascular and connective tissue disorders. Connective tissue diseases like SLE, dermatomyositis, DM, discussed later, and progressive systemic sclerosis, PSS, all have characteristic skin and GI manifestations, see Chapter 37. SLE patients prototypically have malar erythema with Fig 25.2, the erosive form of oral lichen planus involving the buccal mucosa. Note the lace-like keratoses, erythema, and ulceration. Fig 25.3 Pyostomatitis vegitans in a patient with UC. A biopsy specimen revealed microabscesses. 362 Part 4 Topics involving multiple organs: photosensitivity and often erythematous raised patches with follicular plugging, discoid lupus. SLE patients can have oral ulcers. Patients with PSS often demonstrate generalized sclerotic skin or, less commonly, morphea, sclerotic plagues with ivory-colored centers, matted telangiectasia, and Raynaud phenomenon. Immune complex vasculitis of small vessels, leukocytoclastic vasculitis, appears on the skin of dependent sites as crops of palpable purpura and is mediated by deposition of immune complexes in postcapillary venules, Fig 25.5, see chapters 38 and 80. Although GI involvement can occur in any case of small vessel vasculitis, it occurs in 50% to 75% of patients with Henoch-Schönlein purpura, Fig 25.6, Point 14. Vasculitic hemorrhage, bowel wall edema, and intussusception affect the jejunum and ileum most commonly. Direct immunofluorescence of early skin lesions reveals deposits of IgG in most cases of small vessel vasculitis and deposits of IgA in Henoch-Schönlein purpura. Polyarteritis nodosa, sometimes associated with hepatitis B, is a vasculitis of the medium-sized and small arteries. Arterial lesions of the abdominal viscera can lead to infarction of the gut, liver, and gallbladder and to ischemic pancreatic necrosis, as well as to GI infarcts or perforation. Involvement of the appendix, gallbladder, or pancreas can simulate acute appendicitis, cholecystitis, or pancreatitis. Cutaneous involvement occurs in 25% of cases, most typically manifesting as 5 to 10 mm nodules distributed along the course of the superficial arteries. A mottled livedo vascular pattern is also frequently seen. Malignant atrophic papulosis, de Gauss disease, Kohlmeyer-de Gauss syndrome, progressive arterial mesenterial vascular occlusive disease, or disseminated intestinal and cutaneous thromboangiitis, is a vasculopathic disorder that may occasionally be familial. Approximately 200 cases have been described. There is a purely cutaneous form, but the multi-system subtype is important because of its implications for a nearly uniformly fatal outcome due to GI perforation, see Chapter 37. Cutaneous lesions are the initial manifestations, appearing most commonly in early adulthood. They appear as crops of asymptomatic, pink, 2 to 15 mm papules that rapidly become umbilicated and develop a characteristic atrophic, depressed, porcelain white center, Fig 25.7. These lesions represent cutaneous infarcts. Similar infarcts may occur in the GI tract in up to 60% of cases but may also involve the nervous system, heart, lung, liver, and kidney. Although GI involvement may initially be asymptomatic or nonspecific, an acute abdominal catastrophe eventually occurs, often necessitating laparoscopy or laparotomy. Perforation of the intestine is usually found, along with multiple white, yellowish, or rose-colored flat or slightly depressed patches below an intact serosa, usually in the small intestine. Cerebral and peripheral nerve infarcts develop in about 20% of patients, leading to neurologic complications that can include hemiparesis, aphasia, cranial neuropathies, monoplegia, sensory disturbances, and seizures. Microscopy reveals that the infarcts are consequences of non-inflammatory thromboses. The Fig 25.4 pyoderma gangrenosum in a patient with UC. Courtesy Drive. Benjamin Lockshin, Silver Spring, MD. Fig 25.5 Cryoglobulemic vasculitis caused by a drug. This type of vasculitis may also be seen in patients with chronic hepatitis C, although generally not as severe as shown here. Fig 25.6 Skin lesions of Henoch-Schönlein purpura. Fig 25.7 Malignant atrophic papulosis, de Gauss disease, with cutaneous lesions of different stages. Chapter 25 Cutaneous manifestations of gastrointestinal and liver diseases 363-25 Pathogenesis of de Gauss disease is unknown, but identical lesions have been reported in SLE and in a patient without SLE with anticardiolipin antibodies and a lupus anticoagulant. Treatment has been attempted with antithrombotic agents such as aspirin, ticlopidine, and dipyridamole, with limited success. 15 HHT, or Osler-Weber-Rondeau disease, is a group of autosomal dominant disorders characterized by vascular lesions including telangiectasias, arteriovenous malformations, and aneurysmal vessels involving the skin and internal organs, lung, brain, and GI tract. Epistaxis, 80% to 90%, and GI hemorrhage are the most common complications, see Chapter 38. The skin lesions are 1 to 3 mm macular telangiectasias of the face, lips, tongue, conjunctiva, fingers, chest, and feet, Fig 25.8. Skin lesions appear later than the epistaxis, usually in the second or third decade of life. In the fifth to sixth decades, recurrent upper and lower GI hemorrhage may occur. Vascular malformations have been reported in the GI tract, liver, lungs, central nervous system, genitourinary tract, and almost every other organ system in the body. Management of the GI bleeding may be difficult, but the use of bipolar electrocoagulation or laser techniques has been beneficial, see Chapter 20. Associated von Willebrand factor deficiency may be present, and therapy with desmopressin has been successful in treating massive GI bleeding. Chronic therapy with estrogen and progesterone may reduce bleeding from GI telangiectasias. Although there is presently no FDA-approved treatment to prevent development of telangiectatic lesions in patients with HHT, current research is focused on the proposed genetic pathway involved. Mutations in the transforming growth factor beta signaling pathway, including ENG, ACVRL1, and SMAD4, might be targets for anti-angiogenesis drugs such as bevacizumab and thalidomide. 16 Blue rubber bleb nevus syndrome is a rare disorder of the skin and GI tract comprising a constellation of multiple cutaneous and GI venous malformations. Most cases are sporadic. In affected patients, blue, subcutaneous, compressible nodules develop on the skin, Fig 25.9. GI vascular malformations are common, especially in the small intestine or colon, and bleeding is an almost universal feature. Acute GI hemorrhage, intussusception, volvulus, bowel infarction, and rectal prolapse have been described. Treatment is primarily surgical or with photocoagulation. Amyloidosis commonly has prominent cutaneous and oral manifestations, see Chapter 37. Waxy papules around the eyes, nose, and central face, as well as purpura involving the face, neck, and upper eyelids, are frequently noted. If a waxy papule is pinched, hemorrhage will ensue. Pinch purpura. Orbital purpura after endoscopy, vomiting, or coughing is almost diagnostic. Macroglossia, increased tongue firmness, enlarged submandibular structures, and lingual indentations from the teeth occur in 20% to 50% of patients. The macroglossia may interfere with eating and closing the mouth and may cause airway obstruction with apnea, especially in the reclining position. The enlarged tongue may be highly vascular, resulting in bleeding. Recurrent hemorrhagic bully in the mouth are common. Patients may have carpal tunnel syndrome, edema, the shoulder pad sign, amyloid deposits in soft tissues around shoulders, GI bleeding, peripheral neuropathies, rheumatoid arthritis-like deposits in small joints, and cardiac involvement. Congestive heart failure or arrhythmias account for death in 40% of patients with systemic amyloidosis. Diagnosis of amyloidosis can be made by subcutaneous fat aspiration or by bone marrow, rectal, skin, or tongue biopsy. Pseudoxanthoma elasticum is a rare autosomal recessive disorder of the ABCC6 gene characterized by aberrant calcification of mature elastic tissue. Skin lesions are usually the initial manifestation, appearing in the second decade as yellow to orange papules, plucked chicken skin, on the lateral neck, Fig 25.10. Skin lesions may progress caudally, involving other flexural areas, e.g., axilla, groin, antecubital, and popliteal fossae. Calcification of the elastic tissue of arteries leads to the major complications of retinal bleeding, intermittent claudication, premature coronary artery disease, and GI bleeding. Up to 13% of patients experience GI bleeding, which is usually from the stomach, and often no specific bleeding point is found. As opposed to the other complications of pseudoxanthoma elasticum just noted, GI bleeding tends to occur in younger patients, average age, 26 years, often occurs during pregnancy, and may be recurrent. Skin lesions may not be visible at the time of bleeding. Because apparently normal flexural or scar skin may yield diagnostic findings, a blind skin biopsy may be indicated in a young person with GI bleeding with no other explanation. Lesions identical to those seen on the skin may also be present on the lower lip and the rectal mucosa. 17 Neurofibromatosis type 1, NF1, von Recklinghausen disease, is defined by its cutaneous manifestations of 6 or more café au lait spots, each with a diameter greater than 5 mm in prepubertal persons, and Fig 25.8 flat telangiectasias of the lips and vermilion border in a patient with hereditary hemorrhagic telangiectasia, Osler-Weber-Rondeau disease. Fig 25.9 fingertip lesion in a patient with the blue rubber bleb nevus syndrome. Fig 25.10 characteristic plucked chicken skin appearance in a patient with pseudoxanthoma elasticum. Courtesy Dr. Benjamin Lokshin, Silver Spring, MD. 364 Part 4 Topics involving multiple organs greater than 15 mm in postpubertal persons, multiple soft papules, neurofibromas. Fig 25.11, or a single plexiform neurofibroma, and freckling of the axilla or inguinal areas. GI involvement occurs in 10% to 15% of patients with NF1. Intestinal neurofibromas may arise at any level of the GI tract, although small intestinal involvement is most common. These tumors are generally submucosal, but may extend to the serosa. Dense growths known as plexiform neurofibromatosis of the mesentery or retroperitoneal space may lead to arterial compression or nerve injury. Other tumors may occur in neurofibromatosis. There is an increased incidence of pheochromocytoma, with or without the multiple endocrine neoplasia type IIB syndrome. 18 Duodenal and ampullary carcinoid tumors, sometimes producing obstructive jaundice, see Chapter 34, malignant schwannomas, sarcomas, and pancreatic adenocarcinomas are seen with increased frequency. GI manifestations of NF1 include abdominal pain, constipation, anemia, melena, and an abdominal mass. Serious complications that have been reported include intestinal or biliary obstruction, ischemic bowel perforation, and intussusception. Involvement of the myenteric plexus has resulted in megacolon. Mastocytosis is characterized by mast cell infiltration of the bone marrow, skin, liver, spleen, lymph nodes, and GI tract. It occurs in adult and pediatric patients, see Chapter 37. In children, the most common lesions consist of a large red to brown plaque, solitary mastocytoma, multiple red to brown papules or plagues, urticaria pigmentosa, or diffuse cutaneous involvement, with or without flushing or blistering. In adult patients, most have urticaria pigmentosa type lesions, Fig 25.12, sometimes with prominent telangiectasia. Lesions are often on the trunk. The spectrum of clinical symptoms is due to either organ infiltration by mast cells or release of mast cell mediators, e.g., histamine, prostaglandins, leading to headache, syncope, flushing, sweating, shortness of breath, wheezing, or even anaphylaxis. The most common GI complaint is dyspepsia and often peptic ulcer disease caused by histamine-induced gastric hypersecretion, see Chapter 51. Diarrhea and abdominal pain are also common problems and can be accompanied by malabsorption. 19 In children, the lesions usually involute spontaneously, and systemic disease is uncommon. In adults, cutaneous lesions may resolve as well, but without improvement in systemic symptoms. In the rare pediatric case with a solitary mastocytoma and significant systemic symptoms, excision of the skin lesion may resolve the systemic complications. Extracutaneous involvement should be considered for adult patients with cutaneous mastocytosis, because management of symptoms can easily be achieved. Cutaneous manifestations of gastrointestinal malignancies. Cutaneous manifestations may be of importance in recognizing individuals with cancer or from a kindred with a high risk for development of cancer. These cutaneous markers are discussed in 3 sections: syndromes with GI polyposis and skin findings, cutaneous markers of internal malignancy, and cutaneous manifestations of metastatic GI carcinoma. Polyposis syndromes. The polyposis syndromes, discussed in Chapter 126, have a number of cutaneous findings that are key to clinical identification and unique discrimination. Table 25.1 reviews the pertinent mucocutaneous and clinical findings, as well as the genetics associated with polyposis syndromes, hereditary non-polyposis colorectal cancer, HNPCC, Lynch syndrome, and Muir-Torre syndrome, Fig 25.13. A recent thorough review of this topic is available. Point 20 Internal malignancy and related disorders. DM is manifested by a violaceous color of the eyelids, often with edema, heliotrope, keratotic papules over the knuckles, Gottron papules. Fig 25.14, a widespread erythema, often with accentuation over the elbows and knees, Gottron sign, resembling psoriasis, photosensitivity, and nail cuticle abnormalities, including telangiectasies, thickening, roughness, overgrowth, and irregularity. About 25% of patients with DM have internal malignancy, particularly patients older than 40 years. Point 21 Cancers most commonly associated with DM are gastric, colorectal, pancreatic, ovarian, lung, and non-Hodgkin lymphoma. There does not appear to be a predilection for either gender. To detect an associated cancer, a complete medical history, physical examination, including rectal, pelvic, and breast examinations, CBC, routine serum chemistry analysis, serum protein electrophoresis, fecal occult blood tests, urinalysis, chest X-ray, and, in women, mammography and transvaginal ultrasound are recommended yearly, and with new symptoms, for the first 3 years after the onset of DM. Any abnormalities should be investigated further. Point 22,23 Keratosis palmaris et plantaris, Howell-Evans syndrome, tylosis and esophageal cancer, is an adult-onset diffuse hyperkeratosis of the palms and soles that has been described in association with a very high incidence of esophageal carcinoma in several kindred in Liverpool, England. It is an autosomal dominant phenotype caused by loss of heterozygosity of the TOC, tylosis esophageal cancer, gene, RHBDF2, located on chromosome 17q.24. The skin lesions appear during adolescence or early adulthood, and the carcinomas appear on average at 45 years. Esophageal carcinoma develops in almost all patients in these kindred with tylosis. Fig 25.11 Neurofibromatosis. Fig 25.12 An adult with urticaria pigmentosa. Reddish-brown freckle-like lesions are characteristic of the adult form of this disease. The term urticarial is a misnomer, as these lesions do not resemble hives. Chapter 25 Cutaneous manifestations of gastrointestinal and liver diseases. 365-25 Acanthosis nigricans is a cutaneous finding that manifests with a velvety hyperplasia and hyperpigmentation of the skin of the neck and axillae, Fig 25.15, often associated with multiple skin tags. It is most commonly a manifestation of insulin resistance. However, some patients with acanthosis nigricans have internal malignancy, so-called malignant acanthosis nigricans. In these patients, the extent of involvement may be severe and include the hands, genitalia, and oral mucosa. When acanthosis nigricans affects the hands, it is known as tripe palms, acanthosis palmaris, pachydermatoglyphy, palmar hyperkeratosis, and palmar keratoderma. Tripe palms presents as a moss-like or velvety texture with pronounced dermatoglyphics or by a cobbled or honeycombed surface of the palms and fingers. The associated carcinoma is usually present simultaneously with the acanthosis nigricans, but may not yet be clinically evident. Intra-abdominal adenocarcinomas constitute more than 85% of associated malignancies, with gastric carcinomas representing more than 60%. Survival is short, and more than 50% of patients die in less than 1 year. 25 Paraneoplastic acrokeratosis of Bayes-Aches is a rare but distinctive syndrome associated with a primary malignant neoplasm of the Table 25.1 Pertinent cutaneous findings and genetics of the polyposis syndrome, inheritance, cutaneous/mucosal presentation. Other findings: gene defect, OMIM number, Gardner syndrome, familial adenomatous polyposis variant, autosomal dominant, prepubertal epidermoid, inclusion, cysts. Lipomas, desmoid tumors, dental abnormalities, ostomas odontoma, supernumerary teeth, multiple unerupted teeth, long, pointed posterior tooth roots, 100, 1000 adenomatous colon polyps, congenital hypertrophy of the retinal pigment epithelium, CHRP, malignancies, colon/rectum, duodenum, ampulla of Fata, thyroid, medulloblastoma, adrenal gland, hepatoblastoma, APC, tumor suppressor gene defect, OMIM number 175100, Muir-Torre syndrome, Lynch syndrome variant, autosomal dominant, sebaceous. Adenomas and carcinomas, epitheliomas, keratoacanthomas, malignancies, colorectal mucinous adenocarcinoma, proximal colon usually, stomach, small bowel, ampulla of Fata, endometrium, urologic tract, ovary, live/biliary mismatch, repair gene defects in MLH1, MSH2, MSH6, and PMS2, OMIM number 158320, Peutz-Jeghers syndrome, autosomal dominant, early onset, mucocutaneous melanocytic macules, perioral area, lips/vermilion border, buccal mucosa, lingual mucosa, digits, periocular area, perianal area, hamartoma, 2 GI polyps, any part of GI tract, malignancies, small and large intestine, pancreas, breast, uterus, cervix, testes, STK11, serine/threonine kinase germline mutation, OMIM number 175200, Cowden syndrome, multiple hamartoma syndrome, autosomal dominant, tricholomomas, facial papules, lipomas, acral keratosis, penile lentigines, oral findings, papillomatoses, scrotal tongue/lingual fissuring, buccal/lingual cobblestoning, polyposis, esophagus, stomach, colon/rectum. Hamartomas, bone, CNS, eyes, GU tract, pectus, excavatum, scoliosis, macrocephaly, malignancies, colon/rectum, breast, thyroid, endometrium, PTEN, tumor suppressor gene defect, OMIM number 158350, Cronk-Heidt-Canada syndrome, sporadic, alopecia, patchy, hyperpigmentation, diffuse, nail dystrophy, thinning, splitting, onycholysis, onychomadesis, periodic shedding of nails, diffuse polyposis throughout the GI tract, sparing the esophagus, leading to diarrhea, weight loss, anorexia, GI bleeding, intussusception, and a protein-losing enteropathy, OMIM number 175500, CNS, central nervous system, GU, genitourinary, OMIM, online Mendelian inheritance in man. 366 Part 4 Topics involving multiple organs, upper aerodigestive tract or metastatic carcinoma to the lymph nodes of the neck. All of the more than 50 patients reported to date have had malignancy, including esophageal carcinoma and one gastric carcinoma with cervical nodal metastases. The skin eruption begins acrally as thickening of the periungual skin and marked nail dystrophy. The rash progresses proximally and also involves the tip of the nose and ears. Thickening of the palms and soles ensues initially, with central sparing, which can make walking very painful. Eventually the face and scalp become involved. Treatment of the underlying carcinoma is usually associated with improvement or resolution of the skin lesions. Hypertrichosis lanuginosa, another rare paraneoplastic syndrome consisting of fine, thin, down-like, unpigmented lanugo-type hair, is typically noted on the face, forehead, ears, nose, axillae, limbs, and trunk. Associated manifestations include glossidynia, papillary hypertrophy of the tongue, disturbances of taste and smell, diarrhea, scleroderma, acanthosis nigricans, seborrheic keratosis, adenopathy, and weight loss. Colorectal carcinomas are second only to lung carcinoma in frequency of associated malignancies. Carcinoid tumors produce a number of vasoactive substances that can induce cutaneous flushing, see Chapter 34. The most common carcinoid tumors, appendix and small bowel, do not produce flushing until the vasoactive substances reach the systemic circulation. Flushing, therefore, generally denotes metastasis to the liver or a different primary tumor site, e.g., lung or ovary. Glucagonoma is a very rare neuroendocrine tumor of the alpha cells of the pancreas that may cause a necrolytic migratory erythema of the skin. The rash is common around orifices, flexural regions, and the fingers. Lesions are typically papulovesicular, with secondary erosions, crusting, and fissures appearing in a geographic circinate pattern, Fig 25.16. Patients can also often have weight loss, diarrhea, anemia, psychiatric disturbances, hypomenocidemia, and diabetes. The rash typically clears with successful removal of the tumor, discussed in more detail in Chapter 34. Subcutaneous fat necrosis and polyarthralgia is associated with pancreatic acinar cell carcinoma, pancreatitis, and pancreatic pseudocysts. This constellation is now increasingly referred to as the PPP syndrome, pancreatitis, paniculitis, polyarthritis syndrome. Point 26. Most affected persons are men. Deep subcutaneous, erythematous nodules ranging from 1 to several centimeters in diameter usually appear on the legs. In uncommon cases, the nodules may break down, exuding a creamy material. Arthritis, often involving several joints, especially the ankles. Fig 25.13. Mucocutaneous pigmentation in a patient with Peutz-Jeghers syndrome. AB. Fig 25.14a. Dermatomyositis with erythematous plagues, especially over the knuckles, Gottron papules. B. Calcinosis cutis from dermatomyositis with caput medusae. Courtesy Dr. Benjamin Lockshin, Silver Spring, M.D. Fig 25.15. Acanthosis nigricans on the neck. Courtesy Dr. Benjamin Lockshin, Silver Spring, M.D. Fig 25.16. Necrolytic migratory erythema in a patient with glucagonoma, characterized by rapidly eroding, superficial blisters. Lesions are usually localized to the buttocks, groin, perineum, elbows, hands, feet, and perioral area. Courtesy Dr. Carl Grunfeld, San Francisco, CA. Chapter 25. Cutaneous manifestations of gastrointestinal and liver diseases. 367-25. And knees, may accompany the nodules or occur without skin lesions, Fig 25.17. Abdominal pain may be absent when the skin lesions or arthritis occur. In addition to the expected elevations of serum lipase and amylase, eosinophilia is common. Histopathologic evaluation of skin lesions usually reveals diagnostic findings: pale staining, necrotic fat cells, ghost cells, and deposits of calcium in the necrotic fat. The mortality rate in cases not associated with carcinoma can approach 50%. In PPP syndrome, subcutaneous nodules usually manifest on the anterior shins. A bluish discoloration of the skin, ecchymosis, around the umbilicus, sometimes associated with hemorrhagic pancreatitis, is called Cullen sign. When a similar process occurs in the flank, it is called the Gray-Turner sign, see Chapter 58. Some cutaneous markers historically thought to be associated with internal malignancies have more recently been dismissed as having no direct relationship. These include Bowen disease, cutaneous squamous cell carcinoma in situ, and skin tags. Leser-Trelat sign, sudden appearance of multiple seborrheic keratoses, remains controversial but may be more specific for a GI or lung adenocarcinoma when associated with another paraneoplastic finding, such as malignant acanthosis nigricans. 25. Sweet syndrome, acute febrile neutrophilic dermatosis, might be associated with a lymphoproliferative neoplasm. Cutaneous metastases. Cutaneous metastases occur rarely with GI adenocarcinomas. They may appear anywhere on the skin and are often nonspecific, very firm, dermal or subcutaneous nodules. When metastasis to the umbilicus occurs, intra-abdominal GI carcinoma is found in more than half of cases and gastric carcinoma in 20%. This lesion is called Sister Mary Joseph nodule. Immunoperoxidase markers have assisted pathologists in predicting the primary site of origin from biopsy specimens of metastatic nodules. Cutaneous manifestations of liver disease. Liver disease can result in a variety of cutaneous manifestations, especially in relation to hepatitis B and C, boxes 25.1 and 25.2. Pruritus is a distressing complication of cholestatic, inflammatory, and malignant liver diseases. The itching of liver disease is not relieved by scratching or topical glucocorticoids, may be especially prominent in the palms and soles, and can be difficult to manage. Amelioration of pruritus with ultraviolet B light treatment, cholestyramine or rifampin does not help in elucidating the pathogenesis of this distressing condition. Opiate antagonists may relieve pruritus of liver disease, and the pruritus associated with metastatic disease to the liver has been successfully treated with ondansetron, a 5-HT3 receptor antagonist. Intense ongoing research is being applied to the field of itch, and multiple potential itch pathways have been proposed, including receptor activations of TRPV1, opioid receptor, 5-HT, histamine receptor, GABA receptor, neurokinin 1, TRPA1, and others. 27 Frequently administered to patients with liver disease and hypoprothrombonemia, vitamin K cutaneous reactions, although rare, may occur after subcutaneous, intramuscular, or intravenous administration. Large, erythematous, indurated, pruritic plagues occur within a few days to a few weeks. These reactions may be a delayed hypersensitivity reaction, in that dermal testing can reproduce the reactions. When tested, patients have been found to be allergic to the vitamin K, not the benzoyl alcohol vehicle. However, vitamin K3, Synkvite, which is water-soluble, has not been reported to cause similar reactions. If reactions occur after buttock injections of vitamin K, there is an almost diagnostic tendency of these plagues to spread around the waist and down the thigh, reproducing what has been called a cowboy gun belt and holster pattern. These reaction sites resolve over days to weeks but may persist for months to years. After AB Fig 25.17a and b, pancreatitis, paniculitis, polyarthritis syndrome. A 69-year-old alcoholic man with chronic calcific pancreatitis, a pseudocyst, and marked hyperlipemia, greater than 6,000 U/L, developed acute bilateral ankle pain with redness and swelling. 3 days later he noticed painful red bumps in his right posterior forearm and right ankle area, with later spread to the right ankle. He had pain and swelling in several metacarpophalangeal and interphalangeal joints, and bilateral swelling of the Achilles tendon. Biopsy of one of the subcutaneous nodules showed fat necrosis. The lesions and arthritis gradually resolved without scarring over several weeks. Courtesy and Malbas, M.D. Box 251 Cutaneous manifestations of selected liver diseases. Liver disease in general: jaundice, vascular spider angiomata, corkscrew, scleral vessels, palmar erythema, telangiectasia, striae, caput medusa, hemochromatosis, generalized bronze-brown skin color with accentuation over sun-exposed sites, primary biliary cholangitis, xanthomas of trunk, face, or extremities, including striking plain xanthomas on palmar creases, hepatitis B and C. See Box 25.2. 368 Part 4 Topics involving multiple organs and erythematous reaction, or without prior reaction, expanding sclerotic plagues with violaceous borders similar to those of morphea have occurred months to years after injections. The latter pattern usually occurs after large parenteral doses of vitamin K. In addition to these local reactions, anaphylaxis after intravenous administration that may be fatal may occur. The association between polyarteritis nodosa and hepatitis B is well documented. Urticaria and serum sickness classically occur in patients with hepatitis B, although both have been reported in association with hepatitis C, see chapters 79 and 80. Chronic hepatitis C virus is associated with leukocytoclastic vasculitis with cryoglobulinemia. Petechiae and palpable purpura are noted on the skin. Porphyria cutanea tarda, PCT, is a disorder of porphyrin metabolism characterized by skin fragility, blisters, hypertrichosis, and hyperpigmentation in sun-exposed skin, Fig 25.18. PCT is the commonest form of porphyria and is characterized by a deficiency of uroporphyrinogen decarboxylase. Diagnosis is typically made with a 24-hour urine collection demonstrating elevated uroporphyrin levels. Alcohol consumption, estrogens, iron, and sunlight all are known to exacerbate PCT. There is a clear and substantial link between PCT and hepatitis C. 28 The prevalence of hepatitis C in patients with PCT demonstrates regional variation, ranging from 65% in Southern Europe and North America to 20% in Northern Europe and Australia. 29 Treatment involves phlebotomy and antimalarial agents. LP is a common idiopathic inflammatory disorder that can affect skin, hair, mucous membranes, and nails. See earlier. The prototypical presentation of LP is violaceous, polygonal, flat-topped papules of flexural areas of the wrists, arms, and legs. The papules often have an overlying reticulated white scale known as Wickham striae. An association between LP and hepatitis C exists but is not as prominent as the link between PCT and hepatitis C. 30 Drug-induced liver disease in patients with skin disease. Dermatologists frequently consult gastroenterologists for evaluation of patients who are being treated with methotrexate or retinoids, because these medications can cause acute and chronic liver disease. See Chapter 88. Methotrexate is commonly used for severe psoriasis and psoriatic arthritis but is also used for cutaneous T-cell lymphoma, connective tissue diseases such as rheumatoid arthritis, and other inflammatory disorders. Methotrexate is usually given as a single weekly dose of 10 to 25 mg, but may be used in higher dosages in selected patients. A grading system for liver biopsies has been established and is generally followed by dermatologists, with decisions on continuation or discontinuation of treatment frequently based on the results of these biopsies. Table 25.2.26 Latest consensus guidelines from the American Academy of Dermatology recommend less frequent liver biopsies than those previously prescribed. Box 252 Cutaneous manifestations of hepatitis B and C. Hepatitis B more than in hepatitis C. Polyarteritis nodosa, urticaria, serum sickness, infantile papular acrodermatitis, Giannotti-Crosti syndrome, erythema nodosum. Both hepatitis B and C. Small vessel vasculitis, urticarial vasculitis, pruritus, erythema multiforme. Hepatitis C more than in hepatitis B. leukocytoclastic vasculitis with cryoglobulinemia, porphyria cutanea tarda. Hepatitis C lichen planus, livedo reticularis, necrolytic acral erythema. Fig 25.18 Porphyria cutanea tarda characterized by non-inflammatory blisters and erosions of the dorsa of the hands. Affected patients are frequently infected with HCV. Courtesy Dr. Timothy Berger, San Francisco, CA. Table 25.2 Grading system for liver biopsy findings in patients taking methotrexate and guidelines for continuation/discontinuation of methotrexate. Grade criteria guidelines: I normal, mild fatty infiltration, nuclear variability, portal inflammation may continue to receive methotrexate. 2. Moderate to severe fatty infiltration, nuclear variability, portal tract expansion, portal tract inflammation, and necrosis may continue to receive methotrexate. 3. Mild fibrosis, formation of fibrotic septa extending into the lobules, may continue to receive methotrexate but should have a repeat liver biopsy after approximately 6 more months of methotrexate. Alternative therapy should be considered. 3b. Moderate to severe fibrosis should not administer further methotrexate. Exceptional circumstances, however, may require continued methotrexate, with follow-up liver biopsies. 4. Cirrhosis, regenerative nodules as well as bridging of portal tracts, should not administer further methotrexate. Exceptional circumstances, however, may require continued methotrexate, with follow-up liver biopsies. Modified from Roenick HHJR, Auerbach R, Maybach H, Weinstein GD. Methotrexate in psoriasis, revised guidelines. JAM Academic Dermatol 1988, 19:145-56. Chapter 25 Cutaneous manifestations of gastrointestinal and liver diseases 369-25 and no longer suggest pre-treatment liver biopsies in patients without risk factors for additive hepatotoxicity, e.g., chronic alcohol use, obesity, diabetes mellitus, active or chronic hepatitis. Notably, liver biopsy is still recommended for monitoring in psoriasis, every 3.5 to 4 grams total cumulative dose, 32 due to the chronic liver damage caused by the inherent metabolic disorder that accompanies severe psoriasis, but a growing body of work suggests that liver elastography or other non-invasive tests may supplant the need for as many biopsies as are performed today. 33 Retinoids, e.g., isotretinoin, acitretin, bixarotene, derivatives of vitamin A, are currently used for the treatment of certain forms of severe psoriasis, cystic acne, and other disorders of keratinization. Regular evaluation of liver chemistry tests is required during this treatment. Mild elevations of serum triglyceride, cholesterol, ALT, and AST levels are common. 20% to 30% of patients treated, usually transient, or easily managed by reducing the dose. Severe or even fatal hepatitis has been reported, however. Retinoids may be used for patients with psoriasis who were previously treated with methotrexate or who have pre-existing liver disease contraindicating the use of methotrexate. Limited experience suggests that these patients do not suffer progression of their liver disease with such retinoid therapy. As with methotrexate, there is a poor correlation between liver chemistry test results and liver histology during retinoid therapy. Therefore, pre-treatment and intermittent liver biopsies may be required for certain high-risk patients being chronically treated with oral retinoids. Parasitic diseases of the skin and gastrointestinal tract. The larval forms of human and animal nematodes may cause migratory erythematous skin lesions called creeping eruptions. See Chapter 114. The most common pattern is cutaneous larva migrans, caused by dog and cat hookworms, Fig 25.19. Pruritic linear papules migrate at a rate of 1 to 2 cm daily on skin sites that have come in contact with fecally contaminated soil, usually the feet, buttocks, or back. Lesions resolve spontaneously over weeks to months. Larva occurrence is due to Strongyloides stercoralis larva migrating in the skin. It occurs in two forms, one localized to the perirectal skin in immunocompetent hosts and another disseminated form occurring in immunosuppressed hosts. S. stercoralis has the unique capacity among nematodes to develop into infective larvae within the intestine. These infective larvae may invade the perirectal skin in infected immunocompetent individuals, causing urticarial, erythematous, linear lesions that migrate up to 10 cm a day, usually within 30 cm of the anus. Skin lesions may occur intermittently, making diagnosis difficult. In immunosuppressed hosts, repeated autoinfection through the intestine leads to a tremendous parasite burden, hyperinfection, manifested most commonly by pulmonary disease. In association with hyperinfection, disseminated larva occurrence-type lesions may appear over the whole body, especially the trunk. Petechial or purpuric serpiginous lesions may also occur periumbilically. Parasitic infections are classically considered in the differential diagnosis of urticaria. Except for fascioliasis and hydatid disease, however, a direct relationship with urticaria has rarely been proved. If blood eosinophilia and GI symptoms are absent, stool examination for parasites is rarely beneficial. Dermatitis herpetiformis and celiac disease. Dermatitis herpetiformis, DH, is an extremely pruritic skin disorder most commonly appearing during early adulthood, see Chapter 107. The cutaneous eruption consists of urticarial, vesicular, or bullous lesions characteristically localized to the scalp, shoulders, elbows, knees, and buttocks. 34 The disorder is so pruritic that often all the skin lesions have been excoriated, and the diagnosis must be suspected on the basis of this and the distribution, Fig 25.20. The diagnosis of DH is established by skin biopsy and direct immunofluorescence examination of the skin. Deposits of IgA are found in the dermal papillae at sites of itching and where vesicles are forming. Patients with DH commonly have an enteropathy indistinguishable from celiac disease, CD. Their HLA patterns, including haplotypes B8, DR3, and DQW2, intestinal malabsorption, presence of antibodies to endomysium, EMA, gliadin, AGA, and tissue transglutaminase, TG, and small bowel biopsy findings are similar to those of patients with CD. Despite these striking similarities, fewer than 5% of patients with DH have symptomatic GI disease. Gluten has been shown to be the dietary trigger of DH. Even patients with such minimal bowel disease that bowel biopsy findings are normal improve on a gluten-free diet. Reintroduction of gluten in a symptom-free patient on a gluten-free diet leads to the reappearance of pruritus and skin lesions. Fig 25.19 Cutaneous larva migrans characterized by a serpiginous erythematous migratory lesion caused by an infection with dog hookworm. Courtesy Dr. Timothy Berger, San Francisco, CA. Fig 25.20 Dermatitis herpetiformis characterized by pruritic, urticarial papules and small blisters concentrated over the elbows, knees, and buttocks. Courtesy Dr. Benjamin Lokshin, Silver Spring, MD. 370 Part 4 Topics involving multiple organs. Fig 25.21 Lower extremities of an older man with Whipple disease. Perifollicular hemorrhage is apparent. Plasma vitamin C levels were decreased. The skin lesions rapidly disappeared after vitamin C supplementation. Courtesy Dr. Mark Feldman, Dallas, TX. Fig 25.22 Infant girl with acrodermatitis enteropathica secondary to nutritional zinc deficiency. She was subsisting on a diet of rice cereal and water. Courtesy Dr. Genevieve Wallace, Dallas, TX. Table 25.3 Nutritional abnormalities and associated skin findings. Nutritional abnormality causes clinical features. Treatment: niacin deficiency, pellagra, inadequate diet, medication, isoniazid, carcinoid syndrome, symmetrical brown-red, blistering, or scaling plagues in sun-exposed areas, glossidinia, atrophic glossitis 4DS, dermatitis, diarrhea, dementia, death. Nicotinic acid, mild, 50 mg orally 3 times daily. Symptomatic, 25 mg intravenously or intramuscularly 3 times daily. Advanced, 50 to 100 mg intravenously or intramuscularly 3 times daily times 3 to 4 days, followed by oral therapy. Zinc deficiency, acrodermatitis enteropathica if genetic, deficiency of essential fatty acids, biotin deficiency, congenital metabolic abnormalities, alcoholics with cirrhosis, hyperalimentation without adequate supplementation, Crohn's disease, superficial scaling eruption, accentuated in groin and around the mouth, alopecia. Zinc, 1 to 2 mg/kg/day orally for acquired form, 3 mg/kg/day. For congenital form, acrodermatitis enteropathica, biotin, 10 to 40 mg/day orally. Intramuscularly, vitamin C deficiency, scurvy, alcohol abuse, Crohn's disease, Whipple disease, follicular hyperkeratosis and perifollicular hemorrhage, ecchymosis, cirrhosis, poor wound healing, corkscrew body hairs, gingivitis with gum hemorrhage, ascorbic acid, 800 mg/day orally, glucagonoma syndrome, necrolytic migratory erythema, glucagon-secreting neuroendocrine tumors of the pancreas, also in setting of cirrhosis and subtotal villus atrophy of the jejunal mucosa, intense erythema progressing to flaccid bully encrusting with rupture, most commonly on the central face, intertriginous sites, thighs, buttocks, and distal limbs, often painful or pruritic. Surgical removal of the tumor, somatostatin analog or zinc supplementation sometimes beneficial while awaiting surgery. Modified from Nievesd, Goldsmith L. Cutaneous changes in nutritional disease. In Friedberg I, Eisen A, Wolf F., editors. Fitzpatrick's Dermatology in General Medicine. New York, McGraw-Hill, 2003. pp. 1399-1412. A pathogenic mechanism has been proposed to explain the relationship between DH and CD. In patients with CD, IgA antibodies are produced in response to tissue Tg2 that is cross-linked to demydate gliadin peptides, derived from dietary wheat, barley, or rye and presented by HLA-DQ2 or DQ8 molecules on antigen-presenting cells. IgA antibodies to the epidermal form of Tg, Tg3, are then thought to form as a result of epitope spreading, and these antibodies eventually form antigen-antibody complexes with Tg3 in the papillary dermis, resulting in the clinical and pathologic findings of DH. This model would explain why DH more commonly presents at a later age than symptomatic. Chapter 25 Cutaneous manifestations of gastrointestinal and liver diseases 371-25 CD, and with less severe intestinal disease, in that epitope spreading likely requires time and continued exposure to gluten. 35 Because it is occasionally difficult to distinguish DH from other blistering skin diseases, a patient with an extremely pruritic eruption may be referred for endoscopy. The finding of an abnormal small intestine consistent with CD in a patient with a pruritic eruption would be highly suggestive of DH, see Chapter 107. The skin lesions of DH respond dramatically to sulfa drugs, dapsone or sulfapyridine, but the gut pathology and skin immunofluorescence are unchanged by sulfa drugs. Treatment with a gluten-free diet leads to gradual clearing of skin lesions, improvement of the intestinal abnormality, disappearance of the IgA from the skin, and decreased dependence on dapsone for control of the cutaneous eruption. 36 Vitamin and mineral deficiencies. Though many vitamin deficiencies result in various skin findings, Figs 25.21 and 25.22, those of most relevance to GI and liver disease are summarized in Table 25.3, along with treatment algorithms. 31, also see Chapters 6 and 104.